Hey team, this is another video for IDT slash NPR, and this video is going to focus on IDT, and most of us have an awareness or an understanding of what IDT is now, but this is a refocus on IDT. What's the purpose of IDT? Well, it's our method of bringing all players to the table to focus on the patient's care and clinical barriers or non-clinical barriers that are standing in the way of that patient being able to transition from hospital setting to the outpatient setting or next level of care. So this is where we as hospitalists have an opportunity to help engage each member of this team, be it nursing, case management, physical therapy, whoever is there, to engage them, and we all take ownership of this process, because like we said before in other videos, this is not just the hospitalist job. It requires each member of this team as well as the patient to be able to move the patient along the continuum of care in the hospital. So we want to use it as that, bringing everybody together, team engagement, and then focus on the clinical and non-clinical barriers that are standing in the way of the patient being able to improve along their health in the hospital. So as you look at the tool that, or actually the work job aid for IDT that we sent out, and I'm going to take a look at it too while we're going through this, I want you to notice a few things that have changed. You'll see some of the order of the columns have changed, so that there is a focus more on length of stay, observation, GMLOS on the front end of that. And this is our opportunity as a team to pause and see where the patient is from that sort of standard, from a I guess an objective standard of where they're at in the hospital. It's not meant to be the be-all, end-all of when a patient leaves a hospital. There may be, as you'll see in the next section, patients that are not clinically ready to leave that have exceeded their GMLOS. But what we want to emphasize in this meeting, or in this bringing this team together at IDT, is to emphasize what can we do to help this patient achieve that GMLOS that's set. And so we want to emphasize that. So this is one of our answers. We're going to move that to the front, and we want everybody to pause at that. And we as hospitalists can help lead this endeavor. The next column that you'll see that's new is medical necessity. And when you look at your care team visual management tool that we reminded you of in the room to pull up, that's also on there, medical necessity. So that we want to see, that's another measure to understand where we're at along the continuum of care. You know, there may be a patient that unfortunately has come into the hospital with acute COPD exacerbation, and then on day 3 or 4, right at their GMLOS, they're ready to leave the hospital, but unfortunately begin to have chest pain, and myocardial infarction occurs. And so, they certainly may be exceeding their GMLOS the next day, or they may not, because you've got some new documentation that can occur, but they may still need to be in the hospital. But this column helps us understand as another way to see if we are on target or where we're at along moving that patient through the continuum of care. So pay attention to the medical necessity, and we want to pause there as well. Remember, you can look at the greens and the reds and the circles and what they mean there, because they are impacting. I want to go back to the GMLOS one more time. One of the things that we found in our first CTR rendition was that some GMLOS did not seem necessarily appropriate, and so sometimes we want to indicate for our utilization review team to see if they can't look at that one more time. So we'll circle that GMLOS. You'll notice that as part of the work aid, to circle the GMLOS on some folks that you may want to look at a little differently, or maybe that patient that had the MI after the COPD. So sometimes that'll impact, sometimes it will not, but that's something that we learned from CTR that we want to then grow our IDT process. So you'll notice those couple of columns. You'll notice a column called IDP 24 hours. That's where our case management colleagues want to be sure that they have the initial discharge plan within 24 hours on patients that are admitted to the hospital. Then I want to go over a couple of more things that are pretty important. You'll see expected DC. So when somebody comes in with COPD, we may say that we expect them to be in the hospital 72 hours. That's our clinical guesstimation of how long a patient will be in the hospital. And then one of the things that we want to take this to the next level with IDT is we want to understand if that person day by day continues to maintain that track to be able to leave the hospital. And if they do not, then we'll look further down the board there to see what's standing in the way. What do we need, or what can we do as clinicians or nurses or case management to impact that, to help them get back on track. So you'll see, let's just say we say somebody's going to leave in 3 days. The next part is the green or the red part, where green means that we feel like they are on track to achieve their GMLOS, and then again, red means that we feel like they are not going to be on track to meet that GMLOS. Again, this is more of an awareness, and then more of an ask of each member of the team. Those folks that are red, what does each member of that team own to help that patient in a way that maybe we could get back on track to them meeting their GMLOS, or improve their health as quickly as possible while in the hospital, and transition them out of the hospital safely, effectively, and coordinating with the outpatient team. So that's the expected discharge. Then you'll notice the D-1s. This was a column in our old IDT that sometimes, I don't know if we had as much emphasis on, or the accuracy. The accuracy on this D-1 was sometimes maybe faulty would be the right word, but we want to really focus on this, because what this D-1 does is help us prepare from a staffing standpoint, helps us to kind of get an idea the following day of where our bottlenecks may occur with surgeries that are coming out, or maybe labor and delivery that needs beds, etc. So we want to really try to accurately predict who is going to be D-1. And then what we want to do with this D-1 is we want to start preparing that patient the rest of the day to be able to be successfully discharged. Finally, we want to identify that patient, or those couple of patients that we can start our day with the following day, those early discharges, so that you may want to ask your nursing colleagues, and this would be where you would ask them at IDT as well as case management, can we get that oxygen delivered first thing in the morning? Can we maybe prioritize dialysis on this patient first thing tomorrow? This is where that conversation can occur. And those that are 930 discharges, maybe the 30-some-odd-year-old with pyelonephritis that you simply need to write an order for, would be in this column of patient eligible for 930 discharge. There will be some work that will then occur regarding this to help make that happen efficiently in the morning. So remember, again, D-1 important, and then we want to try to identify 930 discharge as 930 in quotation marks. So that's something that's new. Remember, your charge nurse, and I'll talk a little bit more about this, they will use this board as a way to say, as they feed back into you in the morning at that 8 o'clock, 6 to 8 a.m. huddle that you have, whether or not we're still on track with those discharges or early discharges. You'll see kind of social work, primary care documentation. Those are columns that we probably are familiar with. The last couple of columns that I want to mention are the columns on notes and the 12-hour review. So if you look at the notes column, there's any barriers with non-clinical aspects of patient care. These may be a handwritten or kind of a sticky note, something that you want to notify there that we need to kind of either escalate if we can't get it accomplished, or things to achieve before that person goes home. Again, the 12 hours, kind of similar to this note section in that if there are some non-clinical barriers that we don't identify or we haven't identified in another section, that's where these guys go, so that on a 24-hour continuum, we can continue to try to remove these barriers so that a patient, when they are clinically ready to leave the hospital, they are able to. So we want to have a little more emphasis on that. And then also we want to have some emphasis at IDT of, remember, this is our second touch point. We have identified barriers in the morning at nurse provider rounding, clinical barriers, and some other non-clinical barriers. This is our next touch point where you can ask the staff, nursing, case management, how are we coming along with these barriers? What is standing in the way of us achieving these barriers? Maybe it's room air saturation. Maybe it's you need to do a face-to-face so that you can help. They have the ability to escalate to you. You have the ability to help them escalate above themselves to get that resolved. So this is a great opportunity, IDT, that we want to take advantage of to help remove barriers to discharge and have more of an emphasis on that. And that's where we as leaders can help engage each member of the team for that. Finally, and I won't say a ton more about this, but if you'll recall, this last part is more of a clinical barriers to discharge, or things that we need to achieve for a patient to be able to leave the hospital. Many of these you will see that were on the nurse provider rounding part that the nurse and the physician were going to communicate with in the room. So this is our touch point here to be sure those clinical barriers are continuing to be removed. And if not, we can escalate. That's where these are escalated for us to be able to impact their removal. That's it on IDT. I guess in summary, just a quick couple of things. Remember to engage each member of the team. It's not a solo sport, so this is where you as a leader of IDT can help engage other members of the team. I would say too, we want to have more of an emphasis on where the patient is in their stay as far as length of stay, GMLOS, and meeting medical necessity. So emphasize that with the team. Emphasize their ownership of that process. Each person owns something. And then last, we want to look at, this is our next touch point, to look at the clinical and non-clinical barriers and escalate those that we need to escalate to try to remove them at this touch point. Thank you, guys.